So next up will be Jacob Niculcea, review of successful 254 Impella 5.5 devices in advanced heart failure.
Hi there, folks. Good morning. My name is Jacob Niculcea. I'm a medical student at the University of Pennsylvania. I work with our shock team under the direction of Dr. Joyce Wald. I'm honored to have the opportunity to speak with you all about our institutional experiences with the Impella 5.5 platform at Penn. I have no disclosures. So by now, most of us are familiar with the Impella 5.5 platform and its ability to improve end organ perfusion and unload the LV. We've been using this device at Penn now for about 4 years. We've treated 247 consecutive patients with 254 Impella 5.5 devices. So what do these patients look like? When they come to us, the majority of patients are Intermax Class 2 at 64%, followed by Intermax Class 1 at 29%, and then a small handful making up the rest at Intermax 3 and 4. By SCAI criteria, 61% are SCAI D, 26% are SCAI E, and then the remainder 13% are SCAI C. The most common etiology of cardiomyopathy for these patients is non-ischemic at 49%, followed by ischemic at 41%. The remainder of patients are made up by a heterogeneous group of post-cardiotomy shock, congenital cases, as well as other etiologies like infiltrative diseases. The most common indication for an Impella at our institution is as a bridge to decision or as a bridge to stabilization in order to be able to complete an advanced therapies eval. The second most common indication is bridge to transplant at 25%, followed by bridge to recovery at 15%, and then bridge to LVAD at 7%. I also want to note 4% of patients did receive an Impella device as a bridge to a complex PCI. So most patients, 45%, are supported for less than 2 weeks on the Impella device, which is the approved duration currently for the Impella. But that said, as you can see, there are plenty of patients that go well beyond 2 weeks, including 21% of patients who are on support for greater than a month. And actually our recent record was 134 days on Impella 5.5 support. So what do the outcomes look like? The 30% of patients are successfully transplanted, 24% receive a durable VAD. Unfortunately, 20% died in the hospital, but fortunately, 15% were able to be discharged off support with recovery of native heart function. In the gray other category, this is mostly patients who were transferred to other institutions, both on or off support, as well as the 3% of patients, which at the time of the creation of this presentation are still admitted, awaiting either transplant or VAD. Complications-wise, there was a 12.5% rate of major complications, the most common of which was stroke at 7.7%. Other complications included pump thrombosis, hemolysis. We had 2 patients that had their pumps migrate out of the ventricle. There was also 2 cases of axillary graft infection. And in total, for these type of pump-related problems, there were 7 patients that required an exchange of their Impella device. So in total, they got 2 devices. I also want to note that for the strokes, most of them occurred within 24 hours of Impella removal, and in fact, most of them occurred basically at the time of surgery. So in total, with all of that said, we still feel that the Impella 5.5 device is an excellent left ventricular support platform. Even at extended durations, 69% of patients were successfully bridged to either a transplant, a durable VAD, or to recovery. And despite the prolonged support times, the complication rate is low, with stroke being the one that we worry about the most. So knowing what we know and using this device for the last 4 years, how have we been changing our practice? There's a few things that we've done, especially with regards to the stroke risk. For one, we've changed our anticoagulation regimen to bival. This is in part to reduce heparin exposure and mitigate the risk of HIT, but we've also up-titrated our PTT goals to between 65 to 75. I'm not a cardiac surgeon, so I can't speak in detail about the techniques, but it sounds like there have also been changes to the way that our surgeons are performing these operations, in particular Impella removals. As you'll recall, most of these strokes are occurring at the time of the surgery. And what is happening, the more recent techniques, is they actually leave the Impella in the heart at the time of heart explant, if it's a transplant surgery, and they essentially cross-clamp across the device and transect it with the aorta, and then it all just comes out at once. The patient at this time is also placed into steep Trendelenburg position with compression of the carotids. And this data, we have been tracking sort of the changes in our outcomes in response to these changes. That data will be presented at ASIO in the coming months. But in general, we've seen a pretty significant reduction in our stroke rate. Now it's, in the last 2 years since these changes have been made, it's floating around the 3% rate. Our surgeons are also great at getting patients on these devices really fast, often in less than 40 minutes, and often with regional nerve blocks. And overall, we feel that the outcomes for these patients are really good. We have an institutional pilot study aimed at caring for these patients outside of our ICUs and into our step-down units, which has only grown in the last year or so. So with that, thank you so much for letting me share.
Why don't we go ahead and open it up to the panel for questions and comments?
So I have a quick question. Great presentation. Congratulations. I cannot imagine as a medical student standing up here and giving the presentation. Yeah. So
pretty nervous.
Good for you. That's awesome. You know, small absolute numbers, but is there a sort of a common element between the patients who sustained a stroke? Is there something that sort of connects them?
In my view, at least from looking at our data, I didn't see any particular trend or particular signal that would indicate an increased risk of stroke, other than the fact that most of these strokes were just happening at the time of the surgery itself. We believe there's probably some sort of embolization event that's occurring at the time that the pump is actually.
But no obvious clot in the ventricle or smoke in the ventricle that was sort of stood out.
Not anything that would have been evident before the explant.
Mark, do you see that at explant? This is not a phenomenon that I'm necessarily aware of, but it's interesting to hear.
I always want to be a little careful, right? Because excellent outcomes are a great program. So and actually I just did a transplant a couple of days ago. So, but actually what I do is as I go on bypass, I just turn it down to P2, make sure everything's okay, then I turn it to P0. Then on full bypass, I just pull it out through the arm. And you always inspect it. And 99% of the time, there's a little bit of fibrin, either on the inflow or outflow, but it's severely attached. And if by echo there's no clot in the LV or anywhere else, our stroke rate is less than 1%. It's like 0.5. But we just actually remove it through the axillary artery after turning it off. I know programs do cross-clamp. It is technically more challenging, and that's why I say I don't know if it is possible, too. You can get error as well because the aorta is not sealed. Yeah.
Excellent presentation and great job. So a couple questions. The strokes, the rate you got, was it most of them embolic, or did you have any hemorrhagic stroke?
Yeah, I believe the vast majority were embolic. I think there were 2 that were hemorrhagic.
Okay. And was there, did you guys look at the bleeding risk in these patients? Any major bleeding like GI or, intra-abdominal? Because this is also one of the major.
I don't think we looked at that. We might have that data somewhere, but I'm not aware of it.
No significant bleeding, just at the axillary site.
Yeah.
Interesting.
I don't have a question, it's more a comment. I think that it's a great report, great.
Can you speak a little louder?
Yes, so sorry.
Sorry.
Thank you so much. It's a very great report, very good job. I think that, in summary, 5.5 Impella is giving us a beautiful opportunity to support our patients. Right now, from my side, I think that change my practice. Now we have time to improve the nutritional status, the recondition the patients, and allow us to recover the patient from the end organ function, from the general condition to go to durable support, transplant, or recovery. Or recommendation. So thank you so much. It's a very great job.
Thank you.
So I have a question for all the panelists as well, because it's been in several presentations, and historically, sort of like VADS, right? They had to stay in the ICU. They couldn't go to the floor or anywhere else. But now, right, they're all on the floor. They're just roaming the hospital. And historically, all our Impella stayed in the ICU until a end treatment. But more and more, they're in a step-down unit, and we're trying to get to where we can actually send them to our heart failure floor. But we have a tremendous amount of resistance from nursing. Actually, hospital administration's okay. It's our nursing staff that feels that it's not safe. Where do you all keep your Impellas after 2 or 3 weeks? Because so many of them are on now, like, a month, right, before you reach an endpoint, and it's so expensive. They're literally wandering around the ICU exercising, and it just makes no sense at all. So, David, where do you keep yours?
Well, so we still keep them in the ICU, but you're right, the good ones are walking around. I admire Penn being able to make a step down. That's great.
Yeah, we have a large volume, more than 300 Impellas, and all of them are in ICU at this time.
It's the same nursing headwinds, and fortunately we have a 32-bed ICU, so there's space, but that's where they are.
I mean, our same star medical student just presented their data on that transition to the step-down unit. I applaud that. We still keep all of ours in the ICU, but I'd like to see that change.
Yes, exactly like Dr. Manrique. We keep all of them in the ICU. We have created a second unit, which is still an ICU, but a more stable patients where they have more access to physical therapy. It does not necessitate being very close to the OR or the cath lab as the main ICU. So we kind of can triage according to the acuity of the patients where each one of them go.
Yeah, it seems like, though, I say hats off to you, because that's tremendous, right? The issue is it seems like at some point, for at least half of them, we should be able to get to the point where they're actually in a step-down unit, or quite frankly, on a dedicated heart failure floor. Because many of them, I say, are not even on inotropes. They're just mechanically dependent. But it does not become cost-effective at some point. I think we have time for maybe one more question or comment. Oh, yes, I can't see.
Yeah, we have
Yes.
2 over there.
Yes,
Sorry.
Ismail Sara from the University of Texas. We have close to 350 Impella 5.5, but the fact that you're experiencing this stroke immediately after removal is a huge clue that this is more an embolic procedure. And you should look into with your neuroradiologist to see, because generally the innominate artery is the first one. So generally these are strokes that are located more commonly on the right side of the brain. And they have some imaging that they can give you some clue if it's multiple areas in the right side, They can have a good idea how to, what was the cause of this. Because if this is embolic, I don't think that switching to bilivardine, drugs and stuff is going to change it. It has to be the way that the Impella is removed if there is any clot at that time. That may reduce even lower the stroke rate in your series.
I can help with that. So it was very early on, and we had 3 that were cardioembolic. So these were patients who likely we were running the PTTs very low, and so after that we raised, so these were cardioembolic that we see in end-stage heart failure patients. And then we also had a few that were within 24 hours of Impella removal. So we're assuming we just dragged clot across the arch and it went to the brain. And that's when we started just cutting the Impella, leaving it the intracardiac part in the heart that's explanted. And we also raised that PTT goal and did the steep Cronenberg and all that. And we really have not had any strokes since then. So that was very early on. And the bivalve's really more to avoid heparin exposure and to decrease the risk of HIT because they're waiting for so long.
One last question, so we can move on, please.
Just a similar comment about the stroke, and I agree it's mostly in whichever side you implant. But one thing you have to look at it, ask the surgeon, when he was implanting, how difficult was implant? If he had a hard time negotiating subclavian to innominate that angle and he had a calcification, when you remove it, you're going to have it. I had a day before yesterday, very sick patient we implanted for PCI and cabbage. We did op-pump cabbage on her. Explanted her, she did very great from revascularization. I had a very hard time negotiating, be able to put it successfully. I took it out, within 24 hours, she had a stroke and she died. And that's the calcium I can see. So that's one thing. Second part, great thing when you're transplanting the patient, yes, that's a similar thing we do. We early on notice it, there is a thrombus develops and causes a stroke. So, but bigger part is LVAD. How do you assess? Because one thing you have to realize, sometimes these patients are 2 or 3 or 4 months on an Impella. They do develop AI. They have at least sometime mild to moderate AI. And how to handle that. That's you have to be discussion with your heart failure cardiologist. If it's DT patient, we like to replace the valve. If it's BTT, even mild to moderate, we leave it alone. So that's one thing, you have to remember that. And a third part, about the Impella, about the anticoagulation, yes, the bleeding is always the most important part, and a lot of people now switching to the bicarb. But so you have to continue on. We still, go with the heparin instead of the bivalve, and as surgery allows it, we, go in a fully anticoagulation too.
Okay, thank you for your comments. We're going to stop because this is going to go on indefinitely. You did a fantastic job, and now we're going to give you a round of applause because that was incredible.